Okay, I guess we are all here. Okay. So let me welcome all of you to this first of a series of policy talks that we will have, sponsored by the Jindal School of Government and Public Policy. I am Naresh Singh. I am the Executive Dean of the school, and I also teach in some, I sometimes call fringe areas, but others say it's niche areas of complexity economics, applied spirituality, and public policy. But today I'm delighted to welcome all of you to this very important area that is so topical in India today, this work on menstrual health policy. I am indebted to my colleague, Manini Oja, who is the first in this series of lectures, and she has been in touch with many of you. And I also want to welcome our panelists who will share their views, but we want this to be an interactive session, so all of you would have a chance to engage and share your thoughts and your work and your views. I, of course, would like to take the opportunity as well to maybe ask people, before I ask our Dean, Professor Sudarshan, to say a few words as well, maybe I just use the opportunity for a quick 1-minute introduction so we get to know each other who are here. The panelists, you can see their names, right? So we know the panelists, and you will, Manini will introduce them formally later on. So maybe if I start at this end, just say quickly where, you know, who you are and where you are located institutionally.
Hi, I'm Menuka. I'm a senior research fellow at JSGP.
Well, we have a
I am Milindo. I am a professor at JSGP. I mainly teach evaluation and design of policy and programs. Thank you.
Hello, my name is Frances. I'm a foreign research scholar. I'm working with Princeton University in the States and Delhi University here, and on like sustainable menstruation and different practices.
Mm-hmm.
Hi everyone, I'm Sakshi. I do have my master's and MPhil in linguistics from JNU, but today I am a menstrual cycle coach, and the topic is of great interest to me. I am invited here by Neha, and I'm looking forward to the talk. Thank you.
Good morning, everyone. I am Farheen Naz, and I am a co-founder and CEO of a social initiative called We the Change that works in the field of menstrual health, hygiene, and menstrual waste management pan-India. Currently, we are in 15 states of the country.
Hi everyone, I am Sheetal Puri. I am from Samvad Sustainable Solutions. I am Director of Design and Training and Menstrual Coach in Samvad Sustainable Solutions, and I'm based in Delhi. And I'm by profession a designer as well.
नमस्कार सभी लोगों को, मेरा नाम संजीव है और 30 साल डेवलपमेंट में काम करने के बाद हमने संवाद सस्टेनेबल सॉल्यूशंस बनाया और हम कोशिश करते हैं कि महिलाओं को सिखा पाएं कि अपने घर में कपड़े के पैड कैसे बनाए जा सकें।
Hi, I'm Neha. I'm a PhD scholar at JSGP, and my work is based on agricultural policies and farmers' livelihood. And I'm here because this topic is quite interesting. Thank you.
Hi, good morning everyone. I'm Indranil. I teach health and development related courses at JSGP.
Hi everyone, I'm Gurpreet Singh and I'm assistant professor at JSGP.
Good morning everyone. I have been invited by Dr. Karan, and I lead an organization called Matrisudha. So I have known for my work on malnutrition globally and India. For the last more than 6-7 years I've been working on menstrual health, and so looking forward to the discussion. Thank you.
Hi everyone, my name is Zara Hasnan and I am an assistant lecturer in JSGP.
Good morning, everyone. I'm Abhinay Thakur. I teach at Jindal School of Government and Public Policy. By training, I'm a development economist.
Good morning, everyone. I'm Preeti. I'm at the Jindal School of Government and Public Policy. I teach environmental and natural resource economics.
Good morning, everyone. My name is Wajahat Munir Khan, and I'm a PhD scholar in the JSGP.
Hi, I'm Sabila Siddiqui. I'm assistant lecturer. Hi, I'm Prachi Vincent. I'm an assistant professor at JSGP and I work with the area of agriculture and labour.
Hi everyone, I'm Neerja Bhatnagar. I'm the National Program Director from Solar International. We are working in all the 26 states. Recently we have done a study. I think I will share the report with you guys.
Hello everyone, I'm Divya Subramanian. I'm a faculty member at JSGP.
Hi, I'm Jyoti Arora Khanna. I'm a doctoral student from Zakir Hussain Center for Educational Studies, JNU, and I'm working in the area of university governance. But this topic interests me because my major is in economics and I'm quite interested to look what that data says and what are the recommendations. Thank you.
Good morning, everybody. My name is Gurpreet Kaur, and I'm an associate professor at Jindal Global Business School, and I teach sustainability and marketing subjects.
Good morning. I'm Chandan Nandi. I joined JSGP's the Department of Government and Public Policy as an associate professor of practice, and I'm supposed to engage with students and faculty to write, comprehensible and jargon-free text. So let's see how it goes.
Hi, my name is Kunal. I'm from Development Solutions. So we provide monitoring and evaluation support to CSOs and government interventions, which are specifically in social sector or public sector. Thank you.
Looks like it stops with me here.
No, because it's you, it's being recorded.
Very good morning. My name is R. Rashmi. I'm a fellow at the Energy Resources Institute, TERI as they call it. And I work in the area of climate change and public policy strategy. And I often teach at the TERI School of Advanced Studies.
Behind you? Thank you.
Hello everybody, good morning. I am Dr. Sharik Hussain. I am an assistant professor at Jindal School of Government and Public Policy, and I am associated with the courses of complex systems and data-driven policy facilitation using data science techniques.
Very good morning to one and all. My name is Arjun. I'm working as a specialist for hygiene, prevention and washing institutions in Waterloo. We basically work on policy and technical support of the government, and also we have some states where we are directly implementing the programs.
Hi everyone, I am Ashutosh. I am doctoral candidate at JNU. So my research interests are in intersectional inequalities in women's health, particularly menstrual health and hygiene.
So everybody had a chance to introduce themselves? Excellent. So with those introductions, I have to say that I'm really delighted at the mix of people we have in the room. I'm sure this is going to lead to a really rich conversation, and this is exactly what we were looking for when we designed this idea. So thanks to all of you for coming, and let me turn it over now to our Dean, Professor Sudarshan, who will say a few words of welcome as well, and then he will hand it over to Professor Manini Ojha, who will then take charge of things. Professor Sudarshan.
Thank you very much. It gives me great pleasure to welcome all of you to this facility that the university recently established. Thanks to circumstances and a brainwave on the part of the Vice Chancellor, who happened to come by and found this was used as a waste dump by Taj Hotel, and he proposed that why don't the university would like to have something in the center of town, and could he have this space? And since they thought it was dirty, filthy, and unsightly, they agreed to a rather low rent for lease, and then the Vice Chancellor, then the university spent a lot of money doing it in the way it now is. And of course, the hotel management, I think in retrospect, feel that they could have got a better deal if they had had the imagination to use this space in the way it's now being used. But we want to make full use of this space. And really the thing is that when we have dialogues of this kind, it's not always possible for everybody to spare the time to commute 2 hours each way to our campus in Sonipat. But incidentally, all of you must visit because it's an attractive campus and it's vibrant because it has students and faculty and it's a residential campus. But on a Saturday like this, I think when we are discussing some policy-related matters, this seems to be a good, ideal setting. Some of us have to commute from Sonipat, like the Executive Dean and I did this morning, and some of my other colleagues have also done that. But we want to make more and more use of this for dialogues on policy and invite interested people. And so I'm very grateful that you've all showed up. Of course, when we have a topic of the kind now, the next thing that I'm going to be asked is, you organized this discussion on menstrual health policy. What is the university doing about it? Are you going to give menstrual leave to students who can't attend classes and so on? And so, obviously, if somebody says we are going to advocate this policy or that policy, you should be prepared to answer the question. Suppose they say, physician, heal thyself. So this is a challenge. What I mean by this is that this is an issue that doesn't get much reflection or thought among policymakers, and when it's brought up, it's not a simple matter that you can say, okay, we can decide. It is very among the policy choices, it is a complex one. And so it requires, not just, this is a good thing to do, but some research, some understanding. And for the most part, public policy is persuasion. I mean, you have to persuade people that this is desirable and necessary to do. So in effect, it's the art of persuasion that public policy is all about. And to persuade, you need a variety of arguments. You need evidence. You need to have some moral compulsion, appeal. All of that gets into it. So it's not simply dry social science or anything like that. It's much more than that. And so we hope to have dialogues that engage with these issues, because if you're running a public policy school, you ought to be learning all the time. I mean, in India, it's not a subject that's commonly introduced in universities. It's fairly new, partly because policymakers in a British system generally come from the civil service, and generally the civil servants who make policy are, assume that because they are smart and intelligent and they've given some thought to something, the policy that they draft must be necessarily good. By definition, intelligent people will do intelligent things. But in reality, policy is not like that. What gets left out of policy are people who are affected by the policy or are supposed to be benefiting from the policy, and they don't generally get a say in the design and formulation of policies. So we hope that this facility will eventually, over time, bring more and more people in government who are charged with this responsibility, who are sensitive enough to understand that it's important for them to have an open mind, to hear scholars and researchers, and to expand their ambit of knowledge and understanding of serious problems, so that when they formulate the policy, they do it with better information and better reasoning and greater empathy to people they are hoping to benefit. So thank you all for coming. I have to introduce you, but you can introduce yourself.
Thank you so much. Thank you, Professor Singh and Professor Sudarshan, and thank you all of you for joining us today for JSGP's first Policy Forum. So today's Policy Forum is on menstrual health and hygiene. And we are hoping to kick off this conversation and engage with an esteemed audience here. So we have a panel of experts in the field. We have Ms. Tanya Mahajan, who's the Director of International Programs at the PAD project and has over 10 years of experience in the market development of health products and services in low-income countries. She has led research and program evaluations on the intersection of health, gender, and WASH through her work at PATH and Development Solutions. Tanya is the co-chair of the Menstrual Health Supplies Workstream at the Reproductive Health Supplies Coalition and the co-founder of the Menstrual Health Alliance India. And she has done extensive work on menstrual health and hygiene, research and advocacy within India and globally. Thank you, Tanya, for joining us. Next, we have Ms. Tanya Rana, who is a research consultant at the Center for Policy Research, and her work is at the intersection of gender, nutrition, health, and public finance at CPR. Thank you, Tanya, for joining us. Unfortunately, Dr. Arundhati Muralidharan could not make it today, but she's been a great source of inspiration and support for us. We have Dr. Karan Babbar, who's an assistant professor at Jindal Global Business School. He's a quantitative researcher and works at the intersection of education and health, focusing on gender. His current work focuses on menstrual health and hygiene, fertility outcomes, women's empowerment, LGBTQ issues, and health and sanitation. Lastly, I'm Dr. Manini Ojha. I'm an associate professor at Jindal School of Government and Public Policy. I'm also a quantitative researcher, and I specialize in the field of empirical development economics. So I'm an economist by training, health, education, gender, and recently I've been working with Dr. Karan on menstrual health and hygiene, and that's what we're going to be talking about today. So today's agenda will start off with my talk on ensuring good menstrual health and hygiene, some government initiatives, and summarizing some findings from our joint work. I will then invite Dr. Karan to take over and discuss some policy recommendations that we have and present some extra findings from our further work. Following that, I invite the panel to comment on our work and bring in their own perspectives on menstrual health landscape in India, the role of NGOs and civil society and government partners, as well as health financing. We will then open the floor for an open discussion with the audience here, and we have, as we have already introduced each other to ourselves, so we don't really need to go ahead and go into the depths of that. So without further ado, let me begin with the motivation for our work. All right, great. So let me begin with the motivation for doing work in the menstrual health and hygiene field. Although menstrual health by itself doesn't really need a case to be made for it. Menstrual health is a state defined as a state of complete physical, mental, and social well-being when it's related with menstrual cycles. So it's such an important and integral part of our lives and of the individuals who menstruate that it's a topic of, it ought to be a topic of discussion across policy discussions across the board. Still, let me go ahead and give it some. Sorry, just a second. Okay. Let me go ahead and still give it some perspective here for our work. So we find that there are studies that mention that many women in India still use cloth to manage their menstrual needs. And here, education and awareness plays a very important role. And I'd like to say that at the outset. because there are studies that document that 80% of women with no schooling continue to use a cloth to manage their menstrual need versus 35% of women with some schooling. So education and awareness at the outset, I'm bringing it here that it plays an important role. Secondly, period products are not really a priority for many households. Before the onset of COVID, only about 40% of women spent, only about 40% of households spent any money on period products. And that saw a massive decline during the COVID lockdowns because mobilization of ASHAs for pandemic care services suffered a lot. There was massive loss of income, and there is anyway social stigma which is associated with conversations around menstruation. There are studies that document that there's enough research that is being done on wealth-based disparities or inequalities, but there is a significant gap that exists around caste-based inequalities, particularly amongst the marginalized individuals who menstruate. Hennigan et al. In 2019, in their study, recorded that girls end up missing school during menstruation due to a lack of gender-segregated washrooms or period products that are available in school. So here, social support from teaching and non-teaching staff is essential. Then Narang in 2022, in their study, recorded that there's a substantial population that cannot afford disposable period products. And so there's widespread period poverty, and if that is tackled effectively, then it has the potential to boost India's GDP by 2.4%. And lastly, it impacts the Sustainable Development Goals, the SDG 3, 4, 5, and 6 that we have for well-being, for quality education, for gender equality, and water and sanitation. Right, so before I move, so the relevant motivations for period product usage and wash facilities can actually be grouped into 3 categories here. Affordability across demographic groups, accessibility in terms of infrastructure and support services across schools, workplaces, and public places, and socio-cultural practices and rule of awareness. Before I go forward, I would like to commemorate India's journey in the menstrual health field. So India has made significant advances in ensuring good menstrual health and hygiene for women and girls since early 2000s. Between 2005 and 2010, the government of India integrated MHH, menstrual health and hygiene, into the role of ASHAs as part of the National Rural Health Mission. In 2010, India initiated the menstrual health scheme to distribute sanitary napkins to young girls, which I believe later the responsibility of which was then given to different states. Then there was the Rashtriya Kishore Swasthya Yojana, which was launched, that was aimed to increase the awareness of and access to sanitary pads. And in 2012, we had the Nirmal Bharat Yatra, a sanitation program, including MHH as an integral part of it. Simultaneously, there have been other similar programs under the Samagra Shiksha Abhiyan, some of which are geared specifically towards promoting the installation of sanitary napkin vending machines and incinerators for safe and hygienic disposal. So with these initiatives, there has been an increase in menstrual product usage in India from a mere 15% in 2010 to 57% in 2015-16 to almost 78% in 2019-20, as suggested by Babar Garipati in 2023. Then in April 2023, the Supreme Court of India advocated for a uniform national policy to ensure the availability of free sanitary pads for girls in classes 6 to 12, and along with the provision of separate toilets for females in all schools. And in November 2023, a national level menstrual hygiene policy was formulated with the aim of breaking the stigma around menstruation, ensuring access to period products and toilet facilities, empowering girls and women, promoting health and sustainability, and to fulfill the SDGs, the SDG commitments. So what we are doing here in our study is we are trying to present an option for a more holistic national menstrual health policy. So given that I am a quantitative researcher, and so is Dr. Karan. We have gone ahead and utilized the National Family Health Survey, Survey Round 5, which was conducted for 2019-21 for our analysis here. So this is secondary data that we analyze, and we analyze different socio-demographic factors that impact the usage of period products and the likelihood of having a toilet facility. So the data, for those of you who are not aware or not familiar with the NFHS data, let me just introduce that to you. The NFHS data is a large representative data for India, which has biomarker informations like height, wealth, height, weight, hemoglobin levels for children, men and women. It also administers separate household questionnaires capturing all information from all members of the household. And separate men and women questionnaires are also administered, where specifically questions which are related to women are asked in those questionnaires. So it covers a wide range of socio-demographic information, health indicators, nutritional aspects. We here focus on menstruation-related questions from the NFHS, and the sample that we analyze is the responses from 241,000 women within the age group of 15 to 24. So following the Supreme Court's directive, we develop a new index called the MHH index, the Menstrual Health and Hygiene Index, which takes into account both the usage of period products and toilet facilities, emphasizing the importance of both factors in ensuring good menstrual health for all. So specifically, the questions that we look at from NFHS. So NFHS asks a question: women use different methods of protection during the menstrual period to prevent blood stains from being evident. What do you use for it, for the protection, if anything? Anything else? And the responses range from cloth, locally prepared napkins, sanitary napkins, tampons, menstrual cups, nothing, and other. So we define a period product variable, a period product usage variable that takes the value 1 for women who use menstrual cups, tampons, locally prepared sanitary napkins, and 0 for women who are using cloth or other objects or nothing at all. Right? And then we also incorporate the information on toilet facilities. So this questionnaire asks about whether you have a toilet facility, and we code that as 1 if there is a toilet facility that exists, which falls under any of these following categories, some of which are flush to pipe water system, pipe sewer system, flush to septic tank, a pit latrine, and so on. And 0 if there is no toilet facility that is available. So then we construct a composite index, MHH index, which takes the value 1 only if women are using period products and have a toilet facility, and 0 otherwise. Then we go ahead and select a host of comprehensive individual and household characteristics here in our model to account for income and wealth, for the awareness that women have, and for socio-cultural context. So to be more specific, the individual information that we utilize in our analysis are women's education, which ranges from primary to secondary to higher levels of education, their mass media exposure, which is the frequency of listening to radio, reading newspaper, and watching television. Then we go ahead and incorporate household level variables. So we have the wealth index in the NFHS sample, which categorizes households as the poorest, poor, middle, and rich income category. We also incorporate the social groups, so OBCs, SC, STs, and general categories are included. We have religion in our model, which is segregated, which is classified by NFHS as Hindus, Muslims, and others. And then we have the area of residence, whether the women are living in rural parts of India or urban parts of India. So just a bird's eye view of the data, the summary shows that 71% of our sample is living in rural regions and 80% of them are Hindus. 45% are from the disadvantaged groups, 87% have completed at least secondary school, and 58% are heavily exposed to mass media. Right? So when we go ahead and analyze this through regression, through a logistical regression, this is the result that we find. So here, what I'd like to show you is that as the education is increasing from no education to primary to secondary to higher, the prevalence of the MHH index is going up, which means the likelihood of better menstrual health is the women have the likelihood of better menstrual health and hygiene and the probability of toilet facility, right? And then we also see that as mass media exposure goes up, from no mass media exposure, which is they're not listening to radio, watching TV, or reading any newspaper, to partial, they're reading or listening. They have some exposure for less than, I think they watch it less than once a week, and then full exposure is they're watching it more than once a week, right? So as the mass media exposure rises, the MHH index also rises. And these effects are statistically significant, which is very important for us empirical researchers, because we're trying to then capture how far away really is our estimate from a zero effect, right? So these effects are statistically significant. We find that, as previous studies have suggested, as the wealth index goes up, the prevalence of MHH goes up. There we see a lot of heterogeneity in the social categories here. When we look at the social categories, the general categories has the highest MHH index, followed by the OBCs, and then by the ST, scheduled tribes, and then the scheduled castes. And as far as religion is concerned, women belonging to other religions have the highest MHH index, followed by Muslims, and then Hindus, right? And we see that urban areas are associated with a higher MHH index compared to rural areas. And these are all statistically significant results that we're presenting here. So just graphically, if I show you what I was saying, as education levels increase, the likelihood of better menstrual health and hygiene goes up. As the mass media exposure increases, the likelihood of better menstrual health and hygiene goes up, and it also goes up with higher wealth index, which is an observation that's already been recorded in studies. We're providing supporting evidence for it. But what's really salient here, in my opinion, is the education and the mass media exposure, because this provides opportunities for targeted interventions for those, and also the fact that these are women who are staying in rural areas are not exhibiting higher MHH, right? So this provides an opportunity and a scope for targeted interventions for women who are living in rural areas who do not have enough mass media exposure. So this really can be utilized through perhaps more ads in the newspaper or more messages through radio, which the women can listen to, and more ads over television. So some of our other work also suggests that mass media exposure is critical in changing women's contraceptive use, for example. So similarly, if women are able to imbibe these messages, which are given through radio or television, there is scope for policy intervention or targeted intervention in this area. And so awareness, which is what I was trying to underscore initially when I started the presentation, that education and awareness does play a very important role, that is being supported by the data here. So that's just summarizing the results that I showed, that it is, the MHH is based on the background factors that we have, and we see that high levels of education is associated with higher MHH, frequent media exposure, increases with wealth and urban residence. So the findings basically highlight the need for policy initiatives to extend focus on individuals who menstruate, and belong to the poorer socioeconomic backgrounds, those who are residing in rural areas who are not exhibiting high MHH, those who have lower levels of media exposure, and those who have lower levels of education, right? So that said, I would like to say that MHH is a multifaceted concept, right? And just mere provision of period products or wash facilities falls short of truly comprehensive support from all strata society. And here I would like to call upon Dr. Karan Babbar to present some policy recommendations that we have apart from these targeted initiatives where we are saying that mass media could play an important role. Thank you.
Thank you, Marini. I guess you very comprehensively explain our study.
So moving on, so actually when we work with secondary data, one of the issues with secondary data is that we cannot have data on everything, right? So when we talk about recommendations, we are using literature as well as the results that we have got from our study to give the future policy recommendations. So the first one is awareness campaigns and behavioral interventions. So I think this is very important, and it completely and very clearly comes out from our study that education and mass media are playing a very big role. Although the policy talks about hardware interventions, which is about including a toilet facility and providing period products, but hardware interventions will never work out very well unless they're complemented by some software interventions. So what we suggest is we should have awareness campaigns via mass media. It's watched by a lot of people, so that can create a lot of awareness. At the same time, we should also have education awareness sessions in schools, because these two things, when complemented together, can help us in dispelling the taboos and myths which are around menstruation, which is quite popular right now. So our next recommendation is provision of menstrual health support in workplaces. So one thing that can very clearly come out is providing period products and adequate wash facilities in the workplaces. That's quite important. Other than that, it would be very helpful if there could be a counselor whom individuals who menstruate can go and could talk to during the time of their periods if they need any kind of help. So that would be very important. Moving on, we talk about tailoring solutions to local context. Manini gave a very brief idea during the conversation that we are talking about providing wash facilities and period products, but like we discussed, we need to provide some comprehensive behavioral interventions as well. So there is a provision of these prevention in the policy, but a larger question is they are saying that it has to be streamlined. Now when we talk about interventions and when we talk about policies, streamlining them across India may not work very well. So for example, something which works in Bihar may not work very well, let's say in Kerala. So we really need to take the local context into account before we make such policy recommendations. So a third part is to ensure that we do a small pilot study. If we are taking findings from, let's say, one intervention, which is, let's say, being done in Bihar to some other context, so ideally that should be done. And central government should give this authority to the states itself, that they can take a call of which intervention needs to be work well in their own states. Moving on, we need to widen the target population. So if we look at the current role, so it's largely on the school or school-going girls. But what about the girls who don't go to school or who are out of girls' schools? And largely, what about the women who are 18 years and above, who have graduated from school? So it's very important that we take care of these women as well. And when I talk about women, we also want to talk about trans and non-binary individuals who also menstruate. I'll talk about them separately in a different point altogether. Next is improving the quality of pads. So there is very small anecdotal evidence that the quality of pads or the pads that are being given to the girls and women, they do not last for the whole menstrual days. So it might be good if we can increase the quality of the pads so that they can last for long. Second, we also need to focus on providing affordability and accessibility, in the sense that we have affordable sanitary pads and it can be accessed very easily by the individuals who menstruate. Moving on, we need to ensure environmental sustainability. So every month, there is almost a waste of 9,400 tons, which is generated because of sanitary pads. Does that mean that should we just stop, using sanitary pads? That's not the case that we are trying to make. But I think we should give women or the individuals who menstruate the agency to choose the period products that they want to use. We tell them about variety of period products which are available in the market, tell them their advantages and disadvantages, and then give them the choice and agency to choose the period product that they want to. Moving on, we need to ensure inclusion of trans and non-binary individuals who menstruate. So there are two things that I wanted to talk about. Now, India recognizes third gender, but have we seen transgender or gender-neutral toilets? We haven't seen them quite in variety, like we look at the gender segregated toilets which are there for males and females. So I think that is first that we need to sort of bring into picture. Second, we also need to ensure that disposable facilities are provided in both female toilets as well as in the gender neutral toilets, because they are being used by the ones who menstruate as well. Lastly, a very small change in terms of norms.
So when we talk about social norms, one of the common terms that we'll be using all the time is menstruators, but it just reduces the term to its bodily functions. So we try to say individuals who menstruate so that it's not very gender biased. That is one. Second, a very common term that we generally use is women's hygienic products, which again creates a gender dysphoria. So we need to, build out of that and maybe try using more gender neutral terms like period products. So these are some of our recommendations. And now I'll move on to our next study, which is sort of an extension of this study. So when I and Manini met, one of the things that we sort of work on SRH issues, and we wanted to understand, what are some key areas that we don't have evidence to. So if you look at the menstrual health literature, there are many papers which talks about the association between period products and reproductive tract infections, but there is no paper which established the causality between the two. You just have a look at the literature and there are hundreds of papers which are talking about it. So to the best of our knowledge, this would be the first paper which is going to talk about, is there actually a evidence between period product usage and reproductive tract infections? Because we are saying too many things about period products, but is there actually an advantage of using period products? So some evidence was required for that, which sort of motivated us to do this study. And I'm going to talk about reproductive infections first. So why reproductive tract infections are so important? It's the second biggest public health concern, which affects the individuals who menstruate, and it almost leads to 17% economy losses at the country level. So clearly it's a very big number, and 1 in 4 women suffer from RTI. So Tanya and Supriya Garikapati from UCD have also done a study where they randomly went to people. So during the sampling, they figure out that 40% of the people whom they selected had one or more symptoms of RTI. And lastly, many of these women were not even aware that they have some kind of RTI. So we feel RTI is more like a hidden pandemic. Women might have it, but since SRH issues are such a big taboo that no one really knows that they're suffering this. So it's very important that we start highlighting these issues, and period products might be one of the ways how we can sort of try to tackle this issue. So now, if we look at menstrual health landscape, I'll let Tanya talk about it, but I'm just going to briefly mention about it. So there are 300 million women in India who are of reproductive age. And as per NFHS data, 50% of them are still using cloth. So now we wanted to show that period products have definitely a clear advantage for managing MHH needs. So we tried to estimate a causal effect of period products on reproductive tract infections, and our results show that there is a negative and statistically significant effect of using period products on reproductive tract infections. So like Manini discussed, here also for period product usage, it takes the value 1 if individuals use sanitary napkins, locally prepared sanitary napkins, tampons or menstrual cups, then it takes the value 1, otherwise it takes the value 0. So like I said, we have again revisited back to NFHS 5. That's where we get most of our data from. So definitely women of reproductive age lies within the age group of 15 to 49. But in NFHS, data on RTIs are asked only to a limited set, which is around 108,000. And period product usage is available only for women 15 to 24 years of age. So when we intersect them, the final data that we found was for 36,116 women, which became our final sample for the study. So NFHS also asks questions about women who report in sexual activities, and there are 3 questions about RTI, which is about, have you ever experienced sex-related illness, abdominal discharge, and genital soles and ulcers? Based on a study by Bhasin et al. These are the 3 items that they generally use for RTIs, which we have used. So it takes the value 1 if one of them if women is exposed to any one of them, otherwise it takes the value 0. And we have used a bunch of socio-demographic characteristics from education, religion, caste, wealth index, area of residence, toilet facility, health insurance, distance to health facility. I won't get much into it. Manini has already explained most of them. So these are our basic results. So if we look at first, somehow it's just not showing. It's okay. If we look at the first three columns, these are our probit estimates, and last 3 columns are our IV probit or the causal estimates. So these 3 columns represent, in the first column, we are just trying to understand association between period product usage and RTI infections. In next column, we add a set of socio-demographic characteristics, and in the last column, we add the socio-demographic characteristics, cluster characteristics, as well as we control for district fixed effects because districts vary, so that's why we are controlling for them. And in the next three observations or in next three columns, we show the similar set of results for our causal estimates. So this sixth column is our most preferred estimate, and if we look at the marginal effects, so using period products leads to decline by 16% in reproductive tract infections for women who are using period products. So that's quite a powerful statement that we are trying to make with this study. We have also done one thing. We have tried to play a little with the period product usage. So we have tried looking this data only when women are using locally prepared sanitary napkins as well as sanitary napkins. And in this particular case, we have seen the same data when women are using disposable period products, which also includes tampons to this. And in all these cases, our results are still coming as negative and statistically significant, thus showing that period product usage definitely helps in reducing RTI infections, and there's a causal estimate for the same. We also divide our sample. We run a few heterogeneity tests. We also divide our sample by area of residence, caste, and age groups, and our results still remain statistically significant and effective. I'll just share that in next slide. So as we can see, so we are interested in this column, which is for marginal effects. So first we are trying to look at results for urban area and then for rural areas. As we can see, there's a decline of 18.3% in the reproductive tract infections for women who use period products in rural areas. When we look at caste, the numbers remain same for both upper and lower caste women, but the effects are quite higher for women who are from upper caste. We saw the same results for women by the age groups, and our results still show a 20% decline in RTIs for women who are aged 20 to 24. So overall, we find very strong and significant results for our study. Based on this, we have some recommendations. So previous studies have shown a negative association between period product usage and RTIs. Our study adds to the causality of the association between them. So the results emphasize on the need for the targeted interventions. So we definitely need to ensure accessibility and affordability of period products, more especially for women and other individuals who menstruate, who are coming from the socioeconomic disadvantaged groups. There are two small caveats that we wanted to talk about before I end this thing. First is period product usage is one of the ways to tackle RTI. It doesn't in any way resolve RTI completely. That is just one way which can help in sort of reducing the numbers of RTI. That is one. Second, our results are based on sample of females who are 15 to 24, since this is the data that we have in NFHS. So it does not include the data for trans and non-binary individuals who menstruate. Second, it also doesn't include the data for women who are 25 years and above. With this, I would like to thank you guys for listening to us so patiently, and we'll be happy to have your questions. Thank you.
I'd like to call upon Ms. Tanya Bahajan now to comment a little bit on our work and then share with us her own experiences. Tanya, over to you.
Thanks, Vandini, and thanks, Karan. First of all, I just want to thank, I think, both of you for taking up this topic as a focus of your research, because, you know, NFHS is it's basically, it's a landmine of data that holds so much evidence for, just as you showed, you know, causality between period product use and RTIs, but there's so much more that we can sort of unearth from the data, but one hadn't really looked at it. So thank you for your work on this. Okay, my effort here today will be to just, I think, take from the work that Manini and Karan have done, and also reflect on other pieces of secondary data available to us and see what does it mean for policy? What does it mean for menstrual health interventions going forward? Okay, so first of all, till date, what do we see in terms of what has happened in our country in terms of menstrual health interventions? The biggest win, the biggest thing that has happened is that period products are more available and accessible, and more number of people who menstruate are using them. So we have 335 million menstruating women in India, and pad use has increased as was shown by Manini and Karan amongst 15 to 24-year-olds from 57% in 2015-16 to 77% in 2019-20. I mean, that data itself is very telling in the fact that whatever has happened in the last decade in terms of pushing period product use has worked. It is a role that the public sector has played hugely in terms of its policies around pushing period product use, but also the private sector. The last almost 4 decades has seen huge interventions from the private sector in increasing. Well, it is for profitable purposes, but it has the impact that the market is increasing and more people are using hygienic products. Market penetration of single-use sanitary products, sanitary pads has increased from 16% in early 2010s to more than 25%, which is a huge number considering the size of the country and the number of menstruating women in our country. So even if it is just 3, 4, 5 companies pushing that agenda, these numbers are a win. I see them, as a win. The industry, which is today valued at around 8,700 crores, has also regained its pre-pandemic annual growth rate of about 10%. Again, a huge potential. This 25% market penetration is likely to increase further by leaps and bounds. And we've also seen over the last particularly decade, lots of innovations in both single-use products and multiple-use products, whether it's in terms of menstrual cups, whether it's in terms of materials used in disposable pads, more compostable materials, whether it's in terms of design, washable pads, period panties. We also have menstrual discs available now. And India, I think, is one of the only LMICs where something like a menstrual disc is available at a fairly, I won't say affordable for everyone, but fairly affordable rate. And the fact that India has a large manufacturing base of its own supports this effort, which is something, again, peculiar for our country as an LMIC, and it is not something that is available to someone, say, in Africa or in Sri Lanka or in Pakistan, where those manufacturing itself is a challenge. Okay, access has increased, yay. But what next? What are the complexities now? What do we need to do further? Overall access has increased, but it's primarily driven by single-use pad uptake. But the job is not done. The data still says that while 77% of girls use hygienic materials, 50% also still use cloth. So that indicates a lot of mixed use. Many people are still using cloth along with pads. One may be using pads during high flow days when one has to go to school or, for work or something, and cloth at home, or when one can't afford. And it also suggests increasing or continuing challenges in affordability. Access is still highly inequitable. Analysis by...
Or it says that the research question is ever used or regular use. So there's a difference between ever use and regular use. Now, an FHS...
It's ever use. It's ever use. So that's why it is also telling of the fact that many people, sanitary pad use has increased, but still a lot of girls and women are still using cloth. And this data is only for 15 to 24 years old. Older women are likely to be using many more older women are likely to be using cloth as well. So the work done by Manini and Karan shows that access correlates with improved socioeconomic indicators, particularly education, wealth, and social category. Use in many poorer states, particularly states like Bihar, is still much lower than the national average. And so one needs to see the equity side of period product access now. Studies indicate that preference from multiple use products is high when they're offered with balanced information around use of the product. So for example, if one were to offer washable pads or menstrual cups along with balanced information about a basket of choices, it increases both uptake of multiple use products, but also awareness in general, and it has the potential to address these inequities. So to what you were saying. Need for comprehensive behavior change investments, including both physical and digital. Again, this is something that you guys both alluded to, the role that mass media can play, but mass media also can be looked at in many different forms. What's the smartphone access these days? What role does digital interventions have to play? Chatbots, there's a lot of work happening there to make further progress in access. The product's access correlated with mass media exposure, I mean, it's pretty evident. You guys have all, I don't know if you've not seen it, but must have heard about Padman, right? Akshay Kumar talking about pads makes a big difference. My organization, the PAD Project, made the documentary Period End of Sentence. It won the Oscar. And after that, we got huge funding to do interventions that was not available before that. Mixed use and inequity suggests opportunities for informed choice, which needs intensive BCC. So while there is the opportunity to offer different types of products, it needs to be accompanied with behavior change communication. It will not work without it. Okay, taking a step back, what does menstrual health mean? Again, Manini alluded to this a little bit. Menstrual health is a state of complete physical, mental, and social well-being, and not just merely the absence of disease or infirmity in relation to the menstrual cycle. This is how a set of global researchers who got together to define menstrual health for global policy and practice, define menstrual health as. When we say period product access has increased, it only addresses this point of menstrual health, which is accessing and using effective and affordable menstrual materials and having supportive facilities, including water, sanitation, and hygiene services for washing the body and hands, changing menstrual materials, etc. And this is the MHH index right now. This is also a big leap because obviously we've seen the data that it contributes a lot, but the rest of it is the next step. I think the narrative right now is the understanding of menstrual health. Is it menstrual health or is it menstrual hygiene? What is menstrual hygiene? How we see it, menstrual hygiene, which is hygienic use of period products, hygienic and access to safe private facilities to manage your menstruation, is an input to achieving the larger menstrual health outcome. So we need to be looking at menstrual health overall as the next step, with menstrual hygiene being the first step input that's been achieved. So if we take the narrative beyond just menstrual hygiene, what does it mean? We've seen that despite increase in access to pads, linkages with health outcomes remain poor. So this is data again from NFHS, and Karan's done a better job of speaking about some of this. Sorry, this is not from NFHS. This is from another study, which was not a causal study, but it did indicate that RTI incidence amongst low-income groups is very high, to the extent of 30 to 44%. However, it also recognized certain contributing factors, which is low awareness about symptoms, which are often associated with menstruation, unhygienic menstrual hygiene practices, and inadequate health-seeking behaviors. These are some of the contributing factors that studies have found that contribute to the RTI incidence. High incidence of hysterectomies, that indicates a culture of silence and poor health seeking for sexual and reproductive health in general, especially beyond issues related to pregnancy and childbirth. So what is reproductive health for us in general? Still the focus is on pregnancy and childbirth and family planning, of course. 11% of women above 45 have had hysterectomies in India. And this percentage is increasing every year. In some regions like Punjab, this is as high as 20%. This is the longitudinal aging study from 17-18. Over-treating issues related to menstrual bleeding, pain, menstrual concerns, which could be, cysts, fibroids, it could be endometriosis. These are likely reasons, and limited conversations around menstrual health, which could be a gateway conversation to more intensive conversations around sexual and reproductive health issues, That's missing. That linkage is missing. Taking the conversation, whether it's an ASHA having that conversation, whether it's a local healthcare provider, a gynecologist in an urban setting, that transition doesn't happen. Third issue is a family planning use trends. Our country has invested a lot over the years on family planning use and pushing family planning methods. But it still paints a picture of poor body literacy. Again, looking at NFHS 5 data, hormonal contraceptive use is low, very low at 7.8%, condoms being the primary spacing method still. Traditional method use is also very low. So traditional method use typically requires knowledge of your menstrual cycle, understanding the menstrual cycle, counting the days, things like that. So that's still very low. Female sterilization, which is, again, alluding to hysterectomies, continues to be the primary family planning method in India, 60%, which is almost 60%. Again, another piece by Karan here, limited understanding of the menstrual cycle for fertility awareness. Only 17% women between 15 to 34 years are aware of the fertile period, with awareness lower amongst young people and women without children. So without an awareness of fertility and of the menstrual cycle, how does one manage, how does one use family planning methods which may lead to changes in your menstrual cycle? Hormonal contraceptive do influence the menstrual cycle. There is, again, increasing work around contraceptive-induced menstrual changes, alluding to hormonal contraceptives. So a better understanding of the menstrual cycle can increase uptake of both traditional and hormonal methods of contraception for spacing. Anemia affects the menstrual cycle and affects menstruation, but linkages are again included. I mean, this is part of the policy narrative, but in effect, it doesn't matter. It doesn't really happen. 57% of women aged 15 to 49 years are anemic, up from 53% in 2015-16, which is affected by diet, health-seeking behaviors, etc. Again, alluded to messaging around menstrual health. Conversations around menstrual health can really be used to drive conversations around nutrition, around better health, better sort of diet practices. There are lots of myths and taboos around diets, especially around menstruation. So that linkage continues to be ignored. Symptomatic identification of RTIs, health seeking for menstrual concerns, linkage of body literacy with contraceptive use, anemia with food practices. These are all areas which now we need to work on to look at menstrual health and not just hygiene. So looking at the policy approach, I mean, like I said, great job done. Period product access has increased. And how did we get here? Since 2011, there's been multiple centrally sponsored schemes and state-sponsored schemes, and some of which you also alluded to, which have focused on creating access and related infrastructure. That's included sanitary pads, mostly disposable sanitary pads, decentralized production machines for sanitary pads, vending machines, waste management infrastructure, but mostly hardware interventions. Some noteworthy examples are listed here. I won't go in detail, but it started with the menstrual hygiene scheme by the Ministry of Health and Welfare in 2011, which then paved the way for many of the state level programs that now are being implemented. I won't go into them in detail. The Ministry of Chemicals and Fertilizers also started the Suvidha scheme through the Jan Aushadhi centers for distribution of pads. Again, the biodegradability of those pads is a question mark, but the initiative in itself is a contributor to increasing access. Kerala, started with menstrual cups in one district in 2019, and now the state has allocated budget for the whole state to pick up cups as an alternative method, and so has Karnataka. Decentralized production of single and multiple use pads, both not seen anywhere else, was done by the Ministry of Development of Northeast region. So these are some examples through which the government initiatives have contributed to increasing pad use. The focus on products and hardware has benefited access outcomes, but the lack of focus on intersectionality, on choice, on behavior change communication is still visible in the inequitable access. And like I said, that's the next step. So will the menstrual hygiene policy address these gaps? It's still the menstrual hygiene policy. It's under development. The draft was out for public comments, and it's actually been a very integrated process with inputs taken from development partners, from field level organizations. So it's been an extremely inclusive process that the ministries followed to develop this policy. Some of the shifts in narrative that we see as part of the menstrual hygiene policy now is the articulation of key sustainable development goals as outcomes because of menstrual health interventions, education, gender equality, and WASH. So there is now a formal acceptance that menstrual health can contribute to larger SDGs. Safe, hygienic, and quality products and the focus on development of comprehensive standards is something that is called out. And there's been a lot of work going on in development of standards for both disposable and reusable pads with the Bureau of Indian Standards, and now also contributing to the ISO process for the same. But there are gaps there as well, which I'll talk about. But the fact that this is called out, the focus on quality, at the end of the day, it is a hygiene product. It needs to be quality. And so that is something that is a positive shift. Products beyond single-use pads are included, are called out. Again, it opens up the conversation on offering choice. There is a focus on enabling environment, which precludes a need to address information gaps. One needs to say that an enabling environment is required to make sure that capacity building of frontline workers happens, that influencers are engaged, that behavior change programs are not just going to adolescent girls, but going to the larger ecosystem. There is identification of need for coordination mechanism across departments. The challenge with menstrual health and hygiene till now has been that there has been no one department where it falls, right? So coordination across different departments has always been a challenge. Who will do what? So the policy specifically calls that out as an objective. All who menstruate is called out, again, with identification of specific vulnerable groups. And private sector and public sector supply chain stakeholders like pharmacists, like retailers, are identified as stakeholders who can influence change. This was not something that was there in the policy narrative till now. However, there are still incremental steps to be taken in terms of how do we use this policy to actually design programs and help states design their interventions around it. How does one go beyond free distribution and address systemic gaps in long-term supply of products? You know, CSRs or government programs are not going to have forever budgets to fund free distribution of products in schools and communities. So how does one invest in addressing systemic barriers to supply chain so markets can provide affordable quality products rather than us being dependent? You know, I always feel like, you know, such interventions continue to increase the dependency of someone who is already in a vulnerable position. Why do we want to make someone who is menstruating more dependent? A market is almost like a tool for democracy, a tool for agency. We have not yet used it. How do we integrate menstrual health within other health initiatives, especially sexual and reproductive health initiatives? What can donors, NGOs, CSOs, development partners, private sector, all of us, what can we do to generate evidence around this, to demonstrate pilots that can help state governments design more comprehensive initiatives taking from the menstrual hygiene policy now? One is that we can help develop guidance for district and block level implementation, which is not there in the policy particularly. Generating evidence for including older women as a key group in all who menstruate. This is something that's still missing in the current verbiage of the policy, and so more evidence is required to demonstrate this, how the health and well-being of girls and women can be improved by making menstrual health and not just hygiene. Guidance for adoption of standards. Standards have been created, but how can they be adopted? What is the process of getting a product certified? Which labs should I go to? What does it cost? And why should one do it? Evidence-based advocacy on taxation. Zero rating or zero VAT on products does not do anything. It has not done anything because it was not a thought-through initiative from an economic standpoint. Prices are sticky downwards. How can we influence taxes at various levels across the supply chain to move prices downwards in the long term rather than spot prices. So more comprehensive evidence and advocacy on taxation is needed. Innovative finance mechanisms to unlock demand and supply. We have seen the role that microfinance and SME finance has played in increasing access to wash services and facilities. That has not yet been leveraged in the menstrual health ecosystem. Working capital loans for SMEs, consumer finance for products which are too expensive to buy upfront are just some examples, but we need to generate evidence on this. Grant-based R&D for local raw material development. The sanitary pad supply chains are highly dependent on wood pulp. There are 3 large manufacturers of wood pulp globally, and it's since COVID, this supply chains has been extremely sort of blocked, I would say, and prices have been increasing. How can we invest in local raw material fibers to be used for development of products? And application of waste management technologies that may already exist for handling menstrual waste. Demonstrating integration of MH with provision of products and services in other health areas. And demonstrating use of digital initiatives as a facilitator of integration, not just for products, but for services. Can we use digital initiatives to get people from information to asking questions to actually getting them to a health facility? There are initiatives already in the SR, in the FP space, in the MCHN space. Can we extend them a little bit? Innovative behavior change methodologies that leverage economies of scope, economies of scale. So if something is happening which is already in the FP space, can be extended? Because the incremental investment will always be lower than creating a new app for menstrual health information, right? So looking at economies of scope in behavior change. Demonstrating supply chain models, again, that offer choice of products to consumers. We are talking about choice, but we haven't really seen any models that work on the ground till now. We need to demonstrate and generate evidence on all of these pieces and more. That's it from me. Happy to answer any questions. And again, thank you, Malini and Karan, for your work, because it's truly, I think, creating a space for us to do advocacy and generate more evidence. Thanks.
Thank you, Tanya. That was really insightful. I'll call upon Tanya Rana now to comment on our work and also talk about health financing, etc. Once she's done, we have the floor open for more discussions with the audience. So Tanya, take it away from here.
Thanks, Manini, Karan, Tanya, for that incredible presentation. I think there's a lot to learn from what currently exists and where we need to go, especially in the private realm, which Tanya very well illustrated. And at the same time, I think the MHH index is a valiant effort in consolidating the socioeconomic and demographic factors that end up affecting access and usage of sanitary products, as well as how toilet facilities can be leveraged towards it. My insights today, I primarily focused on understanding the public provision of menstrual health in India. Now, I will be speaking specifically about the kind of initiatives, especially schemes and programs that exist to fulfill the menstrual health agenda that the policy landscape lays out. And I think this is also a critical differentiation, because a policy is meant to lay a vision. It isn't actionable in any way. Schemes and programs essentially do that. They can be operationalized towards translating that vision into action. So this is broadly the kinds of initiatives that exist at the level of union, state, and local levels. Now, my co-panelists have spoken about a few of them. There is the Rashtra Kishore Swasthya Yojana and the menstrual hygiene scheme at the union level. They were launched in 2014. The RKSK was launched in 2014, and then the menstrual hygiene scheme was launched before that. But it was also integrated under RKSK. And both of these schemes are also subcomponents under the Ministry of Health and Family Welfare's flagship scheme of the National Health Mission. So the intent primarily under RKSK is to promote sexual and reproductive health. And promoting the distribution of sanitary napkins is also a part of it under the menstrual hygiene scheme. Under these, adults and girls are entitled to 6 sanitary napkins at ₹1 per pad. And these pads are meant to be distributed at Anganwadi centers, schools, and also through door-to-door visits by health workers. There is also the Suvidha scheme, which Tanya also spoke of, which are distributed at the PM Bharatiya Jan Aushadhi Kendras, and 8,000 of these centers approximately are currently operational all over India. And the biodegradable pads are available at ₹1 each at these centers. At the state level too, there are several interesting initiatives, and I primarily focus here on 3 of them. There is the UDAN scheme, which was launched in 2021 by the Department of Women and Child Development. And under this, women and girls up to 45 years of age are entitled to free sanitary napkins, a packet containing 6 pads every month. What's interesting is also that frontline workers can avail sanitary napkins from the state as well. And pad distribution similarly happens at Anganwadi centers, schools, like envisioned in the RKSK program. Now, there is also the Mukhyamantri Kishori Swasthya Yojana, a state scheme in Bihar, under which the Education Department gives an unconditional grant to households to buy sanitary products. Now, how this money is used, we do not know. And this money, I don't know if I mentioned, it's 300 rupees annually. It's not a monthly payout, it's an annual sum. Now, there is also the Udita Yojana in Madhya Pradesh. It was launched in 2015 by the WCD department as well. And under this scheme, Udita corners were meant to be set up at Anganwadi centers, and which would dispense free pads to women and girls who sought to avail it. Coming to some local initiatives, which I think are also something that the union and states can think of emulating as best practices from the field or on the ground. So very interestingly, and Tanya also mentioned about how Kerala ended up distributing, a Gram Panchayat in Kerala in the Alappuzha district ended up distributing menstrual cups to women and girls in the village. Karnataka also did something similar in one of its Gram Panchayat. But here, one of the initiatives which has especially caught my attention in my engagement with this work is Purnia's pilot MHM action plan. And this is something that, and I will speak about the need for convergent thinking in menstrual hygiene management and menstrual health planning in general towards the end of my discussion with you. But this plan does a very well job in consolidating not just the distribution of sanitary napkins to women and girls, but also thinking about providing dustbins to household, building incinerators at the village level, onboarding trainers, leveraging existing community networks. They've used Jivikas, which have a presence in over a very good coverage of, I think, 1.3 crore households in Bihar across its Gram Panchayats. And realizing also that the biodegradable pads under the initiative, which might be expensive for women and girls to buy, they are also in conversations with the police and education departments so that there can be an institutional buyer which could then provide these sanitary napkins free of cost to women and girls. In fact, preceding this initiative, MHM-friendly toilets were built in all GPs of Bihar, and this is in all GPs of Purnia district, which is something that no other district in the state has been able to do. So I think this action plan, to me, has an essential ingredient for realizing public service delivery of menstrual health, especially if you want to see it as a public health concern in India. Now let us look at some challenges associated with
वहां मिल जाते सारे ब्रांड सिटी वॉक वो वाला अरे जहाँ तुमने भेजा था ना
Small break. So maybe that's what's happening.
Or maybe they had something important to say. Yeah? All right. Okay. So challenges with scheme delivery, especially at the union and state level, exist across stages of the policy cycle. And here I've represented 3 of those. At the planning stage, for instance, lack of proper consultation with relevant stakeholders can lead to poorly designing the intervention. And we've spoken about this previously as well, about how poor quality of pads, and here I give this example from Asmita Yojana, which still is, I'm not sure about this, I need to go back and check this information, Asmita Yojana in Maharashtra, where the pads were of poor quality because they were non-absorbent and of small size. And this led to women not being able to use the pad. So availability is not the same as accessibility and does not translate into usage, which is an important point. Now, an aligned point to this is also improper consultation with actors in planning decisions. In our conversation with an ASHA worker in MP, we came to know that there is a taboo associated in having a conversation about menstrual health in a Gram Panchayat level planning, primarily because the room is full of men. So ASHA workers, Anganwadi workers, or auxiliary nurse midwives are not even invited to these conversations, or even when they do, they are hesitant to speak on the topic of menstrual health. Now, no formal training also exists at the last mile as a part of any of the schemes that I spoke of at the union and state level. An ASHA worker in Bihar told us that she speaks to her superior, the auxiliary nurse midwife, about properly communicating safe menstrual hygiene and health practices to the women in her village. Coming to the issue of finances, unfunded mandates. So researchers at the Accountability Initiative, where I work, found that sanitary napkins remained undistributed in the Sitapur district of Uttar Pradesh. Why was that? As I mentioned, under the RKSK scheme, there is a component of distribution of sanitary napkins to women and girls, but no funds were earmarked either for the procurement of sanitary napkins or for its transportation. So how would it ever reach the school or the Anganwadi center where the health worker could then provide these pads to women and girls? Even under the menstrual health scheme, there have been no approvals at the state level. So the state program implementation plans, which are then fed into the National Health Mission's budget, there have been no reported approvals from financial years 2017-18 to 21-22. Even looking at DBT schemes, the Mukhyamantri Swasthya Yojana at Bihar, we have no information on the end use of the 300 rupees that is annually provided to households. And lastly, implementation challenges. We know that frontline workers, the AAAs, are poorly compensated. They are overwhelmed, overworked, overburdened. And as a consequence of that, conversations around menstrual health and hygiene might somewhere be not a priority. And this is also to maybe to enhance the conversation around awareness levels of women as reported in the National Family Health Survey. There is a question on conversations with health workers. And when you look at the kind of conversations that never married women have as opposed to women who are married, there is a stark difference in how many of them actually speak about menstrual hygiene to the health workers. And I think, if I'm not mistaken, never married women, at least 23% of them ended up having this conversation with their frontline worker, as opposed to, I think, less than 5% of married women, because everything else, immunization, etc., takes priority. Now, there is also not enough awareness among frontline workers about the schemes and initiatives that exist at their level. So under the Mukhyamantri Kishori Swasthya Yojana in Bihar, for example, when we were trying to have a conversation about the schemes that exist in Bihar, the Anganwadi worker told us that she's not aware of a state or a union level scheme that is operational in her Gram Panchayat. But it's only when women come up to her and try to engage with them is when they, give a few details and ideas about how they can properly maybe dispose of the sanitary napkin or practice hygienically when they're menstruating. Now, under the Udita Yojana, there have been no supply of pads ever since the scheme was initiated, which has very interestingly led to Anganwadi workers at the centers supply pads to women. So what was meant to be coming from the government instead became a personal initiative and endeavor of the Anganwadi worker. But of course, they're not using the personal finances for this. They use some of the grants, unconditional grants under the Saksham Anganwadi and Poshan 2.0, which runs Anganwadi centers. Under it, they keep a certain proportion of the money for providing pads to women. So what?
In the previous challenges,
Yeah.
could you elaborate a little more on the lack of, if you could move to the previous slide, in the lack of plans financing for procurement of sanitary napkins? Because when we look at the policy and the vision of it, it seems like there is scope for innovation, there's scope and requirement, but it would be good to know what is exactly happening at the implementation or at the more at a reception or a delivery end under this aspect.
Yeah, so as you rightly said, the policy vision remains intact, but it is not operationalized because there have been no planned financing under it. And that was the point I made on unfunded mandates. So you have the vision, but you do not have monies allocated for it. So if there are no funds available for even transporting the sanitary napkin to the Gram Panchayat or the Anganwadi center or even schools, then how would you actually make sure that the pad is available to the women and girls who need it? Does that help? Okay. All right, so what do we really need? Where do we go from here, given that challenges exist at the scheme level? We need convergent thinking. And in my conversation with Rahul Kumar, who is an IAS based in Bihar, we were talking about his action plan for Purnia in menstrual hygiene management and the role that the bureaucracy can play in making sure that this is a conversation that can be prioritized. And he said that leveraging community networks is one way to do it. And as I spoke about it initially, Jivikas were trained to go community to community and speak about the importance of menstrual health and hygiene. And I will read this quote from him, which you all can also see, on the role of community participation in MHM planning, that at the GP level, we have included PRI, ward members, and Mukhya in these conversations too. I will not say that the objective has been met, but we have taken the first step. Solid waste management is being talked about everywhere in Bihar. As part of our next step, we should include menstrual health and waste disposal in MHM planning, as it will open areas which are generally considered taboo. Our community cadre of Jivika, with a reach of 1.3 crore households and PRI members, will play a very important role in bridging the community together, which I think is really, really critical. In fact, as a part of this MHM plan, there is also a state-level task force which has participants across departments. So you have the WCD department, you have the health education departments, who are also playing a role in thinking through what can actually be done to use existing resources at the Gram Panchayat level and create the need for menstrual health at the GP level. Now, what this also feeds into is to not think of this as a one department concern. And I know that we have previously spoken about how, because there is no centralized agency, and I know this is also one of your recommendations, there is no one centralized agency, there is no clarity on the landscape and delivery of menstrual health services. But I think there is a case to be made for integrating departmental strengths and providing this service. And this thinking can therefore also help us to break out of departmental silos. And I think that's exactly where we need bureaucrats to come in and say that, okay, this can be done, and how do we use the community at the grassroots to be able to mobilize this change. And a good example here is also the Udan scheme, where an Anganwadi worker who was speaking to us told us that a program regarding the same is run in government schools near us. It has happened 2 or 3 times so far. Senior officials are also present for the same. During the event, the teachers at school and other officials discuss menstrual health. The women and girls of the village participate in it. Now, what does this say? There is clarity on what schools are doing. And it also invokes participation from community members. And not just anyone, the Mukhya, you will have the senior officials and everybody you need to make this a community-driven agenda. And I will stop there with this thought. I hope this was fruitful to also make the case for why public intervention for menstrual health is needed. Thank you so much.
Thank you so much, Tanya. Now, we have about 15 minutes left. I think 12 to 13 minutes left, but I do want to invite any audience members to share your comments and thoughts, your experiences from the organizations you're from. And if you have any questions for the panelists, please feel free to go ahead. We will pass around the mic, and then I'll keep time for everybody. Yeah.
Thank you. My name is Sanjeev. I'm from Lucknow, about Sustainable Solutions. Now we have also to look at 2 data sets. One is 23% approximately get married before the age of 18. And NSV uses 0.3%. This is again NFHS. Now NFHS 5. The point here is until and unless we will make the men involved into menstrual health and family planning, things will not move. Now I'll take the presentation of Tanvi. I was in Bihar, Tanya, sorry. I was in Bihar 2017 when we had the national workshop on WASH, and Rasi has introduced the pad, the cloth-based pad in Bihar. 2017, and this is 24, and still we are groping with the same problem, because the interest or the power we have is very less. We are not united. Either the companies which are manufacturing, what they are manufacturing, what they are promoting. We are again differentiated between pads, tampons, between the sustainable products, between the cups. The point here is, until unless we form a unified front and start working towards it, that we have to reach with appropriate products to the forest of the place. I'll take another example. We both were there in Shravasti, in one of the remote village, and we have seen a delivery at the sub-center happening without the A&M or the CHO, the health worker, CHO health worker, and the child died. So if you look at the ground zero, the realities are very different from what we see from here, and we need more power actually. We need more power. We need more voice. We need more strength. And of course, male involvement into this, because if we don't educate men, this will be again a one-sided fight, and we'll go on talking about it for another 30-40 years. Thank you.
First of all, thank you all of you. This was really helpful and I think very, very essential today. So I have a reflection and one small question. So I want to start with what you shared, Tanya, that we need to go beyond menstrual health and hygiene, and that's what is really important to me. That's what I do. I do workshops on menstrual cycle awareness. I do talk about period products and period language, the language around period, I have an issue with the word period itself now. So that, but I feel we need education around the entire menstrual cycle. Period, the days of the bleed, and ovulation, the two main points, and how ovulation is the primary event, and educating women, men, all individuals around the cycle, the phases, the changes is what we need. And the entire conversation around how to track our cycle, like when you mentioned fertility awareness. So there's got the pill, there's another thing you mentioned, condoms, and then the traditional method, which I'm guessing you meant the natural fertility awareness thing, which is tracking the cycle and understanding where we are ovulating and where's the window. So all of this is so essential today, not just one part of the whole thing. So I'm very glad that you brought up that point, and all of my work is focused there, working with women. Largely, I work with middle and upper class urban women, but I see the lack of information. So many women do not even know why we menstruate or what really happens, what's happening in the ovaries and the uterus. And there's so much fear around menstrual cup, which is where I'll come to. So I want like this was the reflection that I'm really glad you brought that up, and we need to take the whole menstrual cycle in consideration.
And men do not know anything about their girlfriends or wives.
And men?
And men do not know anything about their wives or girlfriends.
Yeah, so the effort has to be from both the sides. Exactly, exactly. We need to educate men as well. Now, my question. So I wanted to ask, is there any data on the usage of menstrual cup in India?
I'd just like to intervene here and suggest that we'll stick to one comment or one question per person. Yeah.
We don't have market data because there is the market is very disaggregated. There's multiple suppliers. For example, for disposable sanitary pads, you have large companies and you can refer to their annual reports to get a sense of the market data. But for cups, we don't have that kind of market sizing data as yet. However, there have been some studies done on acceptability of cups across one which Karan was mentioning too. I was involved in through Development Solutions, in fact, with Dr. Supriya Garikapati, and there have been others, there's an organization called Arth, working in Rajasthan, they work with menstrual cups, which show that acceptability of cups is fairly high among rural and urban lower income women. Primary drivers being, lack of convenience in using and disposing a pad. Whereas for higher income women, where RTI prevalence was quite high, the cup acceptability was low because the convenience of using a cup and the convenience of disposing it is also high. So while we don't have market data right now, we just have these indicators from consumer insights to say where the industry is going. And so there's definitely a scope for introducing cups in low income settings, but with proper and balanced information.
Just to add
Thank
a
you.
small point, if you look at NFHS 5 data, we do have data on menstrual cups now, but it's very small in number. Yeah. So out of 241,000 women, only 803 are using cups, which is almost 0.3%. So the numbers are like really, really small to make any comment. That's why even, we didn't say anything. We can discuss this after.
Right. Thank you, Professor Milindo. You had a question, and then Mr. Rashmi, I'll come to you. And yes, thank you.
Well, I don't have a question. I have a comment, because we at JSGP was thinking for this purpose itself of organizing this series of discussions. What came out from the beautiful presentations from all the 4 panelists was that we know what is to be done, but we are not very sure as to how they are to be done. Everything is known that this is to be done, these are necessary, but we are really not very sure as to how to take up and how to do that. In the context of policy making, we talk about 2 components: theory of change and theory of action. So our policy making in India is mainly concerned with the theory of change. And the next part of the component, that is theory of action, as to how to do that is almost missing. And the fundamental reason behind this is that the policies are designed by one group and they are meant to be implemented by another group, with the designers having no accountability for the implementation of the policy.
Correct.
And that's what Tanya Rana rightly pointed out, that if we cannot link up the theory of action and theory of change, we can have several good theories of change, but with the lack of theory of action, those changes will never be achieved. Just to give one small example, we talk about national policies. We also have 73rd and 74th amendments to empower the panchayat. But not a single national policy has even mentioned once the word Panchayati Raj. In most of the policies, there is no mention of the Panchayati Raj or the communities in getting into the action process of implementing the policy. So this is a fundamental problem that we face. And that is not only true for India. We were doing a book where we have studied 25 evaluation studies by UN organizations. There also it is absent. So we are all inclined as intellectuals to provide the theory of change and then end the process there.
Correct.
So this discussion that has been organized by JSGP and which will go on several issues is precisely implied to find out the theories of action. We just should not stop at giving the theory of change. Thank you very much.
Very nice.
Yes, if I may just respond to that comment, so very rightly said, and I think just an action point, which, and we didn't go into this discussion today, it was a missing piece, is that we have the menstrual hygiene policy at the national level, but what us as development sector partners and researchers and advocates can do with states is help them develop state level action plans, which also don't exist right now. So how do you translate that policy into that theory of action is a piece that we do work on, and we should also bring that into the discourse in working with states and districts.
First of all, let me compliment both the researchers and the scholars for their extremely informative presentation. And so one comment and one question. The comment is that in the hierarchy of solutions, Professor Baba, which you indicated, a public campaign mode and creating awareness and campaign perhaps was the top solution that you provided. My own sense is that since Tanya was talking about a convergent model of implementation where you don't leave out one, it's not an either-or situation. I think we need to take all solutions perhaps together. So what is the best way of doing that? If I draw an example from the public policy space in the area of health, AIDS. The AIDS is clearly something which is very akin to what we are talking about today, both in terms of taboo, difficulties, a social problem which people don't want to talk about, but solution is urgently needed. So how did we overcome the problem of AIDS? Not completely, but to a large extent, because we did it in a campaign mode and in a mission mode. That was the program. But is the government doing that in a mission mode or in a campaign mode now? The solutions which you have all mentioned in your presentations, I think they are all diverse, discrete. I think they are all over the place, but there is no convergent solution. So a convergent campaign is needed. Maybe we can utilize some of the government programs. Maybe I think as researchers you can think more about that. A question to Dr. Tanya. You talked about market-based model to make it sustainable over a long period. What do you have in mind?
That's a much larger conversation which we are hoping to influence actually in the coming months.
We'll go to development.
But a few examples are, for example, just talking about tax. Right now, the approach to tax has been very activist focused. Like just make tax zero. Why are you taxing my period? Without really looking at the economic implications of tax and tax as a lever for influencing markets. So one market-based approach through advocacy will be to look at the structural barriers that are affecting supply chains related to product access and service access, etc. Both at the level of procurement, raw materials, and also at the level of last mile distribution. So how do we, for example, right now in India, we have a huge manufacturing base. Products can be made here. It's the last mile distribution which is a challenge. So how do we provide market models which can connect the product supply chain from wholesale level to the last mile using self-help groups, using community-based organizations, etc. So that example would be a market-based model, and adding consumer financing onto it, adding SME financing onto it to support even product procurement at a wholesale level, for example, would be another component of a market-based model. So it's a very wide area. I don't have one answer, but we are just starting the conversation on this and needing to take it forward.
I could have suggested something, but I leave it to you.
Yes, we're running out of time, so go ahead.
So I'm Arvind. I come from an organization called Matrisudha. So we have just one research on mental health in Delhi. So we're just about to release the findings of the report on 29th of this month. So I will invite all of you to come over and then give us more strength to have the discussion towards the formulation of a state policy and such inclusive policy on menstrual health, and to resonate what Tanya actually already discussed about absence of state action plans or the district action plans. So that's the one. And second is majority of the findings that we have in the research, I think Karan has already contributed by reviewing the report. So it resonates major of the findings in both of the research findings that you have shown up. So I congratulate everyone to have those discussion on the table. Thank you.
Thank you. That's fantastic. It's exactly what we needed. More conversation about this issue. I'm going to development solutions.
Hi. First of all, thank you for the presentation. Quite insightful. So we are doing a study right now where we are assessing different policies and interventions at state and national level. So this clarity would be helpful in that regard also. So I think in your presentation you talked about lack of training or orientations for last mile implementers. So I have a clarification that when we talk about lack of training, is it more of a principle or a planning problem or a more of an implementation problem? Because different policies, different interventions like MHS, they talk about training of ASAs and orientation of Anganwadi workers. We just wanted a clarity in that regard.
So you mentioned that menstrual hygiene scheme does have a component, menstrual health scheme does have a component for training of ASHA workers. But I think it is both a planning problem because a lot of other initiatives do not integrate training modules for frontline workers, perhaps also because of how overburdened they already are. But even at the implementation level, none of the ASHA Anganwadi workers and ANMs that we spoke to, and there were over 16 or 17 of them across Rajasthan, Madhya Pradesh and Bihar, neither of them had received training on menstrual health. So it is a characteristic of both planning as well as implementation.
Thank you, Tanya. Unfortunately, we've totally run out of time, but I do want to, before I end this session, I think we can have more discussions downstairs. But before I end the session, we have participants from the Sulabh Sanitation Mission Foundation. And if you, ma'am, if you would like to come up, they have this comprehensive report on menstrual hygiene management in India that they've come out with. And if you're interested, you may please speak with her a little bit more. Ma'am, if you want to... yes, sure, please go ahead.
Our topic was more from the social side, social part of it. So the title is Combating Silence from Anarchy to Menopause. And yes, there have been innumerable studies, but very restricted social groups like school-going girls or adolescent girls. But in here we had taken the women from 20 to 49 because what happens once they get married and they go? So there was a bigger question: how do you get them? Then we went to Gram Panchayat, and Gram Panchayat was the place where we called out for the women and we spoke about it. And honestly speaking, we went to various social groups, various demography. I'll give you an example of one in Niyamgiri, which we did with PVTGs. I mean, they don't use anything. They just survive on the leaves till date, and some sands and some matti kind of a thing. And they don't even know that from where does it happen, which part of the body it happens. And fortunately, we were in the end of this September, and 2nd October was coming, and the Gram Sabha happens on 2nd October. And for tribal people, this Gram Sabha is very important. And one day before the Gram Sabha, there is a Women Gram Sabha. And whatever resolution has been taken in the Women Gram Sabha has to be accepted in the Gram Sabha. So there we put down all those things, and we got to, at least we got this into the agenda. Now it has gone into the allocation of the budget. Now another part of the ASHA worker was that she was given a permission from the government that we are giving you at 2 rupees, you can charge it at any price and distribute. And those pads will not even survive for 3 hours, let me tell you that. Yes, there are governance leakage, lots of, we'll have to chip in there. I don't know whether we should be chipping in because do we have that kind of a resources? Do we have that kind of a human resource and all that to do that? And my experience of working from women and labor, I would like to say one thing. When we talk about convergence and when we talk about an umbrella kind of an thing, that umbrella policy should come. You know what is umbrella? Ek umbrella खोलेंगे उसमें आपको adjust होना है. Okay, so let's think about it when we are talking about. So when 2011, this child sex ratio, this thing came in, there were so many committees in every district was constituted for child sex ratio. So similar policy recommendation we have given that in that or in other policy or make a separate committee for menstrual hygiene, at least in the beginning, at the district in the Gram Panchayat level. I think in Niyamgiri it has happened. Yes, it is a struggle for a resource crunch organizations like us. We don't have that kind of money, but we should, something like that if we recommend, might see the day of. This is right.
Thank you, ma'am. Thank you, everyone, for participating. And I think we are short on time, but there's so much more to discuss. And we look forward to maybe more conversations on the 29th. And you're most welcome to come and, have conversations with each other regarding this issue, perhaps downstairs or in the lobby. All right. Thank you so much, everyone. Yes, I invite our vice team. Yes.
No, I just wanted to say thanks, but also to let you know that this is the first in a series of forums like this that we will be having. The next one, in fact, is likely to be on education policy, and we will let all of you know through the channels in which you found out about this one. I also wanted to recognize Tanya, the middle panelist here, because she is one of our alumni. So clearly our school is doing something right. So thanks a lot. I just wanted to acknowledge that.
Thank you so much.
All full of stories, actually. But the problem is that how is it that stories are not?
Main work is around menstrual health. A lot of people telling me.
I spotted at least 4 stories, including an article.
First one is
Second
second one is still under review.